Now we proceed to the next session, which is Advances in Coronary Artery Disease Management 2025. The chairperson, moderator for this session is Dr. Yadav Dev Bhatta. Please be on stage. He's a cardiologist working at Norwich Hospital, Kathmandu, Nepal, and he was earlier associated with all of us in Delhi. So we welcome him, sir. The panelists for this session will be Dr. Ashok Omar. I hope he's reached. Dr. Preetam Gupta, who's the ex-president of API. He's not here. Okay. Dr. R.M. Chabra, sir, is the founder president of North Delhi Physician Forum. I welcome you, sir. Dr. N.N. Jha, he's the president of North Delhi Physician Forum. Dr. G.S. Gupta, Dr. Prasenjit Panda, Dr. Pankaj Kumar, who's joined us from Singrauli, and Dr. Vineet Gupta, who has joined us from UAE. I welcome you all on the stage. It's a very important session. It is a 1 hour session, and it will be initially, Manish will set the stage. Dr. Manish Bansal will set the stage with history and echo evaluation, and it will be followed by tribate, which the chairperson will follow it up. Dr. Bhatta, please take over.
Yeah, I think without delay, we'll start with Dr. Manish's talk.
Good morning once again. So, like any other disease, it's very, very important to first pay attention to the patient's presentation. A thorough history and physical examination are extremely important in the evaluation of any patient who comes to us with suspected coronary artery disease. Straight away going ahead with coronary angiography can lead to so many problems and embarrassing situations and disasters that we all have seen in our clinical practice around us on almost daily basis. So thorough history is extremely important. For any patient who comes to us, we need to look at age, gender, other demographic details, occupation and socioeconomic status, because these will influence our assessment of the cause of the patient's symptoms. A patient who's physically very active and is relatively asymptomatic, we can be more comfortable as compared to a person who is into a white collar job and is leading a sedentary life. Then we need to look at cardiovascular risk factors, lifestyle behaviors, and then look at the symptoms in detail. So symptoms, most patients will present either with chest discomfort or dyspnea. So we have to see what kind of chest discomfort it is, how long it's lasting for, where it exactly is, what is triggering it, what is relieving it, and same way for dyspnea. Now, depending on how the symptoms are presenting, we can further categorize these symptoms. For example, for chest pain, we can classify this as typical angina, atypical angina, or non-anginal chest pain, depending on the type and location of the chest pain, aggravating factor, relieving factor. And this can also be scored. 1 point for each of these 3 points. So if score is 3, then it is typical angina. If 2, then atypical angina. Or if 1, then it is non-anginal chest pain. Similarly, dyspnea can also be scored for as 0 or 2. Okay. Now, why I'm talking of scoring this? Because the very important point is that the symptoms and risk factors, they help us assess pre-test probability of CAD. This is something that we don't look at in our clinical practice in the formal manner, but whenever we see a patient, we try to make an impression within our mind that whether this patient is having CAD or not, because then that decides what further investigation we are going to do, whether we are going to go ahead with stress test or CAG or CT. So this is a chart which I've taken from the recent ESC guideline. This is based on Western data, may not be directly applicable to Indians, but it gives a good information that here we have scores 0 to 1, 2, 3, men, women, and number of coronary artery disease risk factors. So based on that, we can predict the likelihood of that person having CAD. Then we have to examine the patient. This will help us further classify the symptoms that the patient has come up with. So height, weight, BMI, pulse, especially peripheral pulse is very important. Pedal edema, JVP, peripheral stigmata of atherosclerosis may be there, which we can look at. And then, of course, cardiovascular system examination, and all patients will also have an ECG baseline. So based on all this, we decide what we want to do. The guidelines recommend that if the probability of CAD is less than 5%, then no further testing is needed. If it is 5 to 15%, then we can take the help of other investigations to further refine the probability. We can look at ECG, we can look at echo, or sometimes coronary calcium score. In some patients, they if they have already got CT coronary angiogram done, then we are wiser there regarding the presence of CAD. If the probability is 15 to 50%, then we can either go for CT. Actually, CT is preferred here, or functional imaging, depending on what is available in our setup. If the probability of CAD is high, 50 to 85%, then the guidelines recommend functional testing as the preferred option. And if very high, then straight away invasive coronary angiography. Now, all this in whole of this process, echo plays a very important role at every step in CAD. So, right from diagnosis of CAD to hemodynamic assessment, compliance of complications of myocardial infarction, and LV remodeling viability assessment, prediction of SCD risk, and for guiding interventions. At every step, echo is very helpful, and I'll show some examples. First, diagnosis of CAD. If we do echo and if we find wall motion abnormality, our diagnosis is already established. No further testing is needed to know whether CAD is there or not. Not only echo will tell us that there is CAD, it also tells us about the site of obstruction, because the wall motion abnormalities depend on coronary anatomy. So, for example, this patient has mid LAD obstruction. I showed you echo. There was only apex which was impacted. So it was likely that the LAD obstruction was not in the proximal part. But in this example, there is more widespread wall motion abnormality. EF is quite low, and therefore, as expected, there is a significant stenosis in proximal LAD. What about this patient? Here, the wall motion abnormality is in inferior wall. So we expect RCA problem, and this is what we find. Now, every time wall motion abnormality may not be because of CAD, that we have to be careful about. For example, in this patient, there is jerkiness of interventricular septum and there is mild global hyperkinesia, but there is no pattern of wall motion abnormality fitting with the coronary distribution. So this is an example of left bundle branch block where the septum is jerky, bouncing. Another example, here there is global hyperkinesia with more marked hypokinesia of septum, typical finding in non-ischemic dilated cardiomyopathy. There are many other conditions in which we can find wall motion abnormalities in the absence of CAD. So we need to be aware of these possibilities. Takotsubo syndrome, post-operative state, pericardial diseases, RV volume overload, sarcoidosis, and so on. How to distinguish these with wall motion abnormalities in CAD? In CAD, overall thickening is compromised, which is not in non-ischemic wall motion abnormalities. And whenever there are non-ischemic wall motion abnormalities, they generally do not conform to coronary vascular territories, except in case of sarcoidosis, where they may create confusion. Then in acute coronary syndrome patients, again echo can play an important role in diagnosis, although the guidelines recommend symptoms, ECG and cardiac biomarkers as the first step. But here is one example. Is this 29 years old gentleman, very young, no major risk factors. He presented to our emergency at 6 a.m. with persistent chest discomfort for 2 hours. This was his ECG, which very surprisingly did not show anything majorly abnormal. But we did echo because echo was available, and as you can make out, the apex is not contracting normally here. So just because of this wall motion abnormality, In the absence of any major risk factors, young age, very low pretest probability, and normal ECG, we proceeded with angiography. And what we found was a huge thrombotic lesion in the proximal LV. So just because of echo, we were able to diagnose this in time. Patient underwent primary PTCA and had normal LVF. If we had missed this, he would have had extensive anti-wall MI. Then in patients who present with stable CAD, we can do stress testing. Here is one example. As you can see, there is wall motion abnormality in LED territory. DSC again showing ischemia. Good diagnostic accuracy of stress echo has already been demonstrated in many studies. Echo is very helpful in hemodynamic assessment. Now these three examples show different EF. This itself makes huge difference to the patient outcome. This patient with very severe LV dysfunction is going to have very bad outcome as compared to this patient. But beyond EF, we can get many other useful parameters like mitral inflow pattern, LV filling pressure, PA pressure, MR. All of these influence outcome in patients with CAD. And then echo is also the best modality for diagnosing mechanical complications. Just last minute. So this is one example of LV pseudoaneurysm. Here we have intramural hematoma of LV apex. This is a patient of papillary muscle rupture. Same patient having TE done. And then this elderly lady presented with ventricular septal rupture on day 4 of her MI. And you can see this defect here in the septum, circular defect. She underwent device closure of the defect. Here we have LV apical clot. So all these make huge difference to the patient treatment, and only echo can provide this information. Then echo is also helpful for assessment of viability. However, the significance of viability assessment has become controversial. But here is one example, dovitamin echo. Lateral wall is hypokinetic at baseline, improves at low dose, worsens at peak dose. So typical biphasic distribution. Lastly, strain imaging has also been used by many for diagnosis of CAD, but strain imaging is not recommended for this purpose because segmental strain is highly variable. So it is not robust enough, and I will recommend against routine use of strain imaging for evaluation of CAD patients. So just to summarize, a thorough clinical assessment and echo are crucial in the assessment of any patient who presents with suspected or known CAD. Echo is pivotal in the evaluation and management of CAD patients, regardless of their clinical presentation, because it provides a vast amount of diagnostic and prognostic information at every step in the patient's journey, which helps drive several key therapeutic decisions, whether the patient is receiving medical management or catheter-based treatment or is undergoing surgery. Thank you.
Thank you, Dr. Manish. It is very, very important to diagnose any disease. By the history, you can diagnose either it is respiratory or the cardiac. If it is cardiac, nowadays echo becomes the stethoscope of the cardiologist, I think. In the ward, we do MR hai, stethoscope se karte the. Nowadays, it just like a stethoscope for the cardiologist. The diagnosis structurally as well as the functionally.
I think it's very, without echo, you can't really think about looking into coronary artery disease. I think it's the first investigation which we have to, including the complications of MI and everything. I think you have covered everything in a very short time. Thank you.
Thank you for excellent presentation. One of my friend had a simple chest discomfort, and we did ECG, stress echo, everything was negative. He was a sportsman and was a good walker. Just to send him for NGO, and he had triple vessel disease. Could you say something that we can screen beyond ECG or echo, such type of patients?
I'll make a comment here. I think ECG and echo are part and parcel of the basic investigation of any cardiac ailment.
Yeah.
Many times we find patient had infarction in the past. He had recovered. ECG is normal. We suspect something wrong. We get an echo done, we find hypokinesia or akinesia of one of the. He undergoes evaluation further. He had an infarct in the past. So it's important to get an echo as and when required, almost always, if we have suspicion of heart disease. whether it is cardiomyopathy or coronary artery disease.
So just to answer his question about a patient who presents with chest pain, ECG, echo are normal,
And he was a very good walker.
what else we can do? So in those cases, strain imaging can be of help. We can do myocardial contrast perfusion imaging also, can see the perfusion defect in the ER itself. But those are things which are for experts, not for routine use.
One thing, sir, like you showed the case, there's only apex was hypokinetic. So with that evidence, other evidence also required for going for the angiography and further if required revascularization.
No, so overall, the patient had significant chest pain, which was not explained by any other etiology, and we saw wall motion in a young patient without any reason. So just on the basis of that, we did angiogram.
And initially, at the time of presentation in acute coronary syndrome, many times one finds the ECG is normal. HS-drop T is also normal. But over a period of next 1 hour or 2 hours, when patient even has recovered from chest pain, we find ECG changes.
Yes.
We find HS-drop.
Yeah.
So that's another thing to keep in mind.
This patient also had significant ECG changes later.
Yeah, what is important is all these tests, including coronary angiogram, has their own limitations.
Yes.
No test is 100%. We have had patients who have got angiography today, and after a week he has myocardial infarction. So even angiography is not foolproof, as Manish has rightly tabulated. The chance, even if you do a nuclear scanning, the sensitivity is around 80 to 90%. Similarly, so there are limitations. There are exceptional cases, but this is maximum the science can do, and this is what we have been doing. Any other comments?
So we can go on
Yes,
to the next
thank you. It is
part.
fact.
Yeah.
Talk later.